For decades, the frontline defense for a mild asthma attack was remarkably simple: the Blue Rescue Inhaler. These devices deliver short-acting beta agonists, or SABAs, which quickly relax the smooth muscle of an actively constricting airway. But relying exclusively on a SABA creates a dangerous biological blind spot. While the drug effectively forces the airway open, it does nothing to resolve the underlying cellular inflammation that triggered the spasm. Leaving this underlying inflammation untreated means the airway remains hyperreactive. The smooth muscle may be relaxed temporarily, but the structural environment is primed for a sudden, severe exacerbation. Because of this risk, the Global Initiative for Asthma, or GINA, issued an urgent clinical warning. They completely removed SABA-only treatment from their recommendations for adults and adolescents, citing significant safety concerns. In its place, GINA established a new clinical gold standard: single maintenance and reliever therapy, commonly known as SMART. The SMART protocol replaces standalone bronchodilators with a single combination inhaler. This device pairs an inhaled corticosteroid, an ICS, with a specific beta agonist called formoterol. This consolidation follows a strict clinical mandate dictated by cellular biochemistry, rather than a mere desire to simplify a patient's prescription regimen. To understand the logic of SMART therapy, we have to look at how these two distinct pharmacological agents, inhaled corticosteroids and beta-2 agonists, operate inside the cell. A common clinical heuristic separates their duties entirely. Corticosteroids are thought to manage chronic, long-term inflammation, while beta agonists handle acute, immediate bronchospasm. Treating these two mechanisms as isolated biological events fails to stabilize the airway because the receptors driving inflammation and muscle constriction are highly interactive. At the molecular level, inhaled corticosteroids and beta-2 agonists actively and reciprocally enhance the efficacy of one another. Recognizing this intracellular synergy is the necessary foundation for understanding exactly why the SMART protocol succeeds where standalone rescue inhalers fail. The process begins when an inhaled corticosteroid enters the airway. Because these molecules are highly lipophilic, they easily diffuse across the lipid bilayer of the cell membrane and enter the cytoplasm. Once inside, the ICS molecule locates and binds to a cytoplasmic glucocorticoid receptor alpha, forming an activated ICS-GR alpha complex. This binding event triggers an immediate structural shift. The newly activated complex rapidly translocates through the nuclear pore and crosses into the nucleus. Inside the nucleus, the complex regulates gene transcription using two pathways. The first is transactivation. The complex binds directly to positive glucocorticoid response elements on the DNA strand. This prompts the DNA to increase expression of specific anti-inflammatory proteins, including annexin-1, MKP1, and IκB alpha. Through transactivation, the corticosteroid compels the cell to actively manufacture its own structural defense system, a proactive response that extends beyond merely blocking inflammatory signals. Simultaneously, the activated complex executes a second mechanism within the nucleus known as transrepression. While transactivation builds new defenses, transrepression aggressively attacks existing inflammation by physically blocking pro-inflammatory transcription factors, specifically targeting the NF-κB complex. This suppression includes an epigenetic component. The ICS receptor complex recruits an enzyme called histone deacetylase 2, or HDAC2. HDAC2 removes acetyl groups from histones, which causes the chromatin to condense tightly. This structural condensation physically switches off the transcription of inflammatory genes. At the same time, the complex initiates a specialized blockade that directly interferes with GATA3 signaling. By suppressing GATA3, the drug stifles the production of T helper 2 cytokines, which are the primary drivers of allergic airway inflammation. The combination of these two pathways is highly effective. Transactivation builds the cellular defense network, while transrepression disarms the active biochemical triggers of an asthma attack. If inhaled corticosteroids are so effective inside the nucleus, we have to look at how they interact with the beta-2 adrenergic receptors sitting out on the cell membrane. The relationship begins from within. The activated glucocorticoid complex in the nucleus directly increases the transcription of the gene encoding the beta-2 receptor, prompting the cell to express more of these receptors on its surface. This outward signaling is vital because frequent use of beta agonists normally causes receptor downregulation and pharmacological tolerance. The corticosteroid prevents this degradation, ensuring the airway remains highly sensitive to bronchodilators. In return, stimulating that beta-2 receptor on the cell membrane sends a cascade signal back inward, directly interacting with the resting glucocorticoid receptors in the cytoplasm. This intracellular cascade drastically accelerates the rate at which those resting glucocorticoid receptors cross through the nuclear pore. By forcing more receptors into the nucleus faster, the beta agonist significantly amplifies the overall anti-inflammatory power of the corticosteroid. These molecules form an interdependent, reciprocal biological loop, where the action of each molecule guarantees the continued success of the other. To leverage this intracellular loop clinically, a drug combination must perfectly map to the timing of this biology. This is where formoterol becomes critical. It is a long-acting beta agonist, but it possesses a remarkably fast onset of action, opening the airway as quickly as a traditional rescue medication. By combining an inhaled corticosteroid with formoterol in a single device, the medication weaponizes that reciprocal synergy loop, providing immediate symptom relief while simultaneously shuttling anti-inflammatory receptors into the nucleus. This dual action allows the SMART protocol to use the exact same inhaler for two different jobs, as a daily maintenance therapy to establish baseline control, and as an acute rescue therapy when symptoms spike. The SMART inhaler represents the physical, clinical manifestation of the biological requirements of the asthmatic cell. Consider a patient exposed to an allergen, experiencing a sudden uptick in chest tightness and wheezing. Under the SMART protocol, when they reach for their inhaler for acute relief, they automatically drive up their anti-inflammatory dose at the exact moment their airway inflammation is spiking. This is known as auto-titration. If that same patient reached for a standalone SABA, they would experience temporary muscle relaxation, but that spike in inflammation would be left completely unchecked, increasing the risk of an emergency. The clinical data validating this mechanism is definitive. This chart shows the rate of emergency visits and hospitalizations for mild asthma patients. Patients using as-needed ICS formoterol saw a 65% reduction in severe events compared to a SABA alone. It also yielded a 37% reduction in emergency visits compared to traditional daily corticosteroids paired with as-needed SABAs. By aligning medication delivery with the cellular synergy of glucocorticoids and beta-2 receptors, the SMART protocol mitigates the risk of severe exacerbations through precise targeting.